Hi, I'm Dave Casper from Glidewell Laboratories. We're here with Dr. Dennis Tarnow, clinical professor of periodontics and director of dental implant education at Columbia University. And Dr. Tarnow, over the last couple of decades, you have no doubt placed thousands of dental implants of all shapes, sizes, and colors, I'm sure.
That's true.
And, but I was hoping today maybe you could share with us your first ever dental implant experience. Who was the patient and why was it that patient? How did you decide to take the plunge?
Well, my first patient was after I took the course in Toronto by George Zob and P.I. Brannemark on how to do edentulous ridges. My first patient was not too far after that. Now we had to, Brannemark wanted everything done in an operating room, as we thought the sterility was absolutely important, because you remember he's an orthopedic surgeon by training, so he wanted everything to be done in an operating room. And I had admitting privileges at a hospital, even as a periodontist, and so I found a patient that was unhappy with his lower denture. I said, and he had a very nice ridge, so we didn't have CAT scans then, we just had panoramic x-rays. So I knew I was in good shape, good bone, picked a good case, you know. So I said I had to have my staff trained too. So I said we showed them, we had mock workups and everything, so we did all that. And so we had to go to an operating room. So here I am, you know, I had to close my office down. I had to close my office for a whole afternoon, make arrangements with the operating room and say, okay, everybody, we're doing an implant case. So everybody was so excited, you know, and we all wind up going and, you know, they go to the hospital and, you know, and so my staff, which isn't normally in a hospital, you know, got dressed up in gowns and they taught them how to scrub in and all
very
this
exciting
kind of
for
stuff.
them, I'm sure.
It was very exciting. So there was a whole bunch of training and it was very interesting. And so, you know, it was also new to the hospital. They had never seen dental implants being done. You know, there was orthopedists there, but not dental implants. So it was a first for them too. So it was all this excitement, all this hullabaloo. And so the patient was a nice guy, and he was almost like a guinea pig for me. And I was hate to say it, but I mean, it's like we never did it before, except on a model. You know, we did on spare ribs. During the training, we had spare ribs just so that we would get the feeling of cortical bone and falling into the marrow. So
right.
That was our training. You know, we did on spare ribs. So that's what was our training. So this was the first time I did it. We had no idea where we were putting the implants. I mean, we didn't know anything about position prosthetically. This was just place it in and then we'd figure out later. It was just the opposite of what we do now. It was just place them surgically and then we'll figure out, you know, with the laboratory, we'll wax up something and figure out where to put them.
It wasn't restoratively driven.
No, it was not restoratively driven. This was strictly surgically driven. Everything was hybrid anyway. It was high-dry. There wasn't an aesthetic zone or anything. So sure enough, we went the whole afternoon, went to the hospital after hours and hours of training, and so we did the implant, and the implants, I put 6 implants in. And my first case, thank goodness, went extremely well. We submerged all the implants, and then 4 months later, at that time we used to wait 4 months, everything was submerged, and then we used to take cookie cutters. Brannemark didn't have us do, he wasn't worried about attached gingiva, so when I look back at it now, I laugh. I was looking at one of the cases this morning, in fact, and he gave us like a cookie cutter, and we used to palpate the ridge and feel out where the cover screw was under the ridge. We had no way to know exactly where it was. So we would feel the cover screw over the ridge, over the tissue, and then we would take this cookie cutter and literally just take the tissue over the top and then put a not a healing abutment. We didn't have healing abutments. There was no healing abutments like we have today. You put the transepithelial component on that the hybrid denture was going to sit on.
The old standard abutment.
The old standard abutment, transepithelial part that stood out. It was no cemented, everything was screwed down. So everything had to be screwed down. So we had to put this in, and then we wound up suturing around that. There was no healing abutment, no caps to protect the patient during this time. It was really like the dark
Didn't they have those old white
They had the old white little stubs that sit on, but they
yeah.
got lost half the time anyway. But that was after we all complained that the top needed protection during this time. We had no idea. So we did do it, and we used to, whenever we did an implant case, part of the reason it cost us money to do these things. We couldn't charge the patient enough to take my whole staff out, and myself out of my earning potential in the office, but it was so exciting. I mean, you know, we went to the office. Well, it was 10 years later that I wrote the article. Patient did fine.
The implant
survived. I was so nervous. My gosh, it was an amazing process to put, you know, to open up the drawer and put these implants in and fall into real bone for the first time. And you know, everything was so new. Everything was so different. It was a different feel.
Did you get any sleep the night before?
No, I really didn't. I didn't get any sleep the night before, and I wasn't asleep that night either. I was calling the guy like every 2 hours. Are you okay? Are you all right? And Brannemark used to have us bring the patients back. The original protocol was to bring the patient back 24 hours later. And I kept saying, why are we doing this? I don't want to see the patient 24 hours later. That's probably the most uncomfortable time is, the 24 hours. I said, let's at least give it a week in the future. But that was part of the protocol, just to make the patient make sure the patient wasn't in need of anything, But it was the worst time to have them come in. But we saw, some of this. And we also did mucobuccal fold incisions. We didn't do crestal incisions. So there were two things that changed as a result of that. I published it 10 years later, in 1992. In 93, I published a paper with David Schaff, one of my graduate students at the time, in periodontics. And I said, Dave, I'm getting calls for lawsuits because, if the patient wasn't treated in an operating room, people were getting sued if they had any failure.
Really?
Oh, it's the biggest thing. Lawyers were all over this. In about 1990, 89, they heard that if you had a failure, it was probably because you didn't do it in an operating room, sterile operating room. You did it in your office. So what happened was, as director of implants and chairman of the department at that time, I said I was tired of getting called and defending these guys for doing nothing wrong. There was nothing wrong. But we had to prove that sterility in the operating room sterility wasn't critical, that you could do the same success rate as we do in an office.
How long before you stopped going to the operating room?
It was about it was close after I realized how much time and energy it took to get everybody over there and back and forth. Probably I did about 8 cases in the operating room. And then I realized this doesn't make sense. I said the bacteria is in the mouth, the saliva is the contaminant. I said what we should do is, and also I didn't like mucobuccal fold incisions. Patients were swollen. We used to go down in the vestibule. Brennemark did this because he was afraid that the incision line over the cover screws would hiss, and so he put the incision down in the mucobuccal fold down in the vestibule. So we opened up the tissue like a trap door,
right,
and then we close it over, and suture it to the lip inside. But it was much more swelling, very uncomfortable for these patients, and so I said, let's just make it into keratinized tissue. And just close it over. It's easy to suture. It's easy and less swelling. And sure enough, that made one big change. The other thing was that eventually we found out, of course, we didn't have to submerge it, especially if there was bone around the implant. The epithelium couldn't get down there anyway. The bone would stop it. So there was no gap and no space. We were fine. So my first case took hours to prepare for, many hours to prepare for. I lost money on it for sure, but then I never looked back. So in 1993. We published this article showing that we showed no difference. At the school, we were doing some in the operating room style, total sterility, and some in clean and sterile, but seen instruments and sterile, of course, but in a clean environment, not an operating room, total sterility. And sterile gloves, of course, and everything, but not the classic sterility like an operating room. And we showed 0 difference. And that was the breakthrough. I said, I'm so tired of this. I know there's no difference. We got to prove it. We got to publish it. And once we published it, all the lawyers went away. It was really unbelievable. But it was a field day for the lawyers. But my first case was quite traumatic emotionally, but it did work. And we waited so many months because it was a machine surface, and that's what we were told to do. We did everything by, we tapped everything. We did everything according to the book. And it did work. So we knew that we were onto something, and we never looked back. It's changed dentistry, of course, and we'll always change it. We knew what works, and we know even more now than we did then, of course, and more predictable implants, more predictable surfaces that we can work with, and better parts connecting prosthesis with screws of different types and different fits, connecting the abutments to the implants. So it's quite an interesting change of pace compared to what we did the first time. Now,
you've come a long way.
Yeah, when you come a long way. Now when my staff says we have a single tooth implant, it takes about 5 minutes, So when I think about what I do to actually place the implant, it takes more time to anesthetize the patient, get the patient seated, and modify a temporary afterwards if there is one or whatever, than it does to place the implant in the normal case. It takes 5 to 10 minutes now, and it's really, the anesthesia takes as much time just to wait for anesthesia. So it's really quite an amazing paradigm shift, but we showed no difference. One of the side things on that, by the way, even with the old machined implant, we were criticized for that article by people saying that, how do you get a 98.2% success rate? In that article, we had a 98% success rate, and it was the machined implant, which we know has a less success rate in general. Now, granted, these were mostly anterior mandible at the time, fully dentures. A good success rate there, of course. But they said nobody was getting 98% success rate, 98.2. I said, they said you must have fubbed your, we don't see that. You must have fubbed your numbers or something, which I was very offended by. And I said, no, that's our numbers. We have the data for sure. So we looked back at why. Well, when I started this at the school, in order to be fair, I created a tumor board. Like a tumor board, I created an implant board. Every patient had to be screened completely, medically. It had to be cleared by the head of perio, the head of pros, the head of oral surgery, and we had a psychologist also meet the patient. You know who nixed most of the patients?
Psychologist.
That's right. The psychologist nixed most of the patients. So the kids would, the graduate students would have to bring all the models and everything and say what they wanted to do in the CAT scans, and then the board would decide whether the patient was there, would be able to be done. When I think about the cases that we did, they were the most perfect cases you'll ever want. Remember, there was no guided bone regeneration then. The patient either, if they had a little amalgam tattoo on their tissue or something, no, we can't do this. We don't know what's going to happen. So we were in such a extended patient had any medical problem of the slightest nature. No. Smoker? No. You know, they looked at somebody funny? No. You know, the expectations are too high. No. You know? I mean, it was really quite amazing process. But by doing that, we learned a lot. And even with the machine titanium implant, we had that 98+ percentile success rate, which we don't have today. All our numbers went off. Why? Because we're pushing the systems, and even though the implants are better, we are pushing the systems to their maximum, especially as specialists. We're being asked to help people that really are in trouble and have very little bone. You need bone grafting. Think of where we are today and just routine. Oh, let's do a sinus lift. Okay, we'll do a sinus lift. You know, and those kind of things. Today it's routine.
Treat everybody.
Well, just about. If they're well enough to walk in and have an extraction, they're usually well enough to have a single implant. That's really the goal, the way that we look at things today. If the person come in is well enough to have local anesthetic in your chair and have a simple extraction done, then they're well enough to have an implant, at least in that area. I think that says it all.
I think
Come
so.
a long way.
Absolutely.
Okay.
Dr. Tarnow, thanks for joining us today.
Thanks so much, Dave. Always a pleasure to see you.
Hi, I'm Dave Casper, Vice President of Sales and Business Development here at Glidewell Laboratories and editor of Inclusive Magazine. We're honored to have with us today Dr. Dennis Tarnow, Clinical Professor of Periodontics and Director for Dental Implant Education at Columbia University in New York City. Dr. Tarnow, welcome.
Thank you so much.
Welcome to Southern California.
Thank you. It's beautiful today. Thank you.
Thank you. Dr. Tarnow, you're known around the world as the leader in dental implant continuing education. Everywhere we go, whether it's undergraduate, postgraduate, you've touched the lives of so many dentists around the world. Tell us about this journey. How did it start? What ignited the passion for continuing education?
Well, it's interesting. I graduated in 1972 and I went for a general practice residency at Brookdale Hospital in Brooklyn. And then I realized that I was being trained beautifully as an intern in general practice, but I wanted to do a lot more. So I wound up doing a double specialty, as you know, in both periodontology and prosthodontics. And I loved education. And as a result of that, it stimulated my entire way of thinking. I realized that I was very fortunate to be exposed to some of the real world's greatest teachers who also had a great dedication. And I think I learned from them to see their passion and what teaching did for me, their teaching did to me and for me and fellow students. And so I think that was what gave me my passion for education. I saw how many people you can touch indirectly as a teacher. I think that when you know, whatever person you touch yourself, you know, as you know, I have a very active group practice in New York City, but when I teach and I lecture to, whether it be 10 people or 2,000 people, to think of how many people that you've indirectly touched. And to me, that's the beauty of an educator. If they can learn even one thing in an hour lecture and take it home, they will do it for the rest of their lives and hopefully propagate better dentistry, but really have a better feeling about themselves. So education has been really inspired by me, by my teachers, and people like Sigmund Stahl in periodontology and Harold Litvak in prosthodontics and Frank Salinger Sr. These are the people that were really, Sidney Silverman, these were great mentors to me. And so then it just carries through that I think I'm just doing their kind of work and continuing that thought process.
And when did you first start the emphasis in dental implants as part of your curriculum in the universities?
As part of that internship that we called it internships then, now it's a general practice residency, GPR, I did it at Brookdale Hospital under Norman Cranen. Unfortunately, Norman passed away last year, but Norman was one of the pioneers in implant dentistry, particularly in subperiosteals and blade implants. He was the first one that developed the what was called an anchor implant, like a modification of the blade. So during that year, we worked with him, and we did some subperiosteals and also did blades. So my first implant was with Norman Cranen, and it was quite an interesting thing. And I was placing implants into edentulous ridges, of course, and they were blade implants. And it wasn't until, that was in 1972, 73, and then it wasn't until 1982 is when I was exposed to it in Toronto. I was exposed in a continuing education course by Dr. Brandemark, P.I. Brandemark, and George Zob.
You were at that original conference?
I was at that original conference. What was interesting for me was that I was being trained as a periodontist and as a prosthodontist. What was always interesting for me is that at the time, no periodontist was allowed to take the course. So I actually took it legally as a prosthodontist. So it was kind of interesting. So for me, it was quite a learning experience. I knew that this was a paradigm shift. And when I saw what George Zob was showing, which was a duplicate of what the Brandemark group had done in Sweden, I realized that this was something totally different. As a perio and prosthodontist, I was saving root tips, I was doing hemisections, root resections, and these teeth were holding fine for a few years, 5 years, 7 years, sometimes even more, 10 years. But I realized when I saw this that there was another world out there. This was the next step to me in perio prosthetics. It was the new root replacement ability. Instead of parts of broken down teeth to keep people away from partials and full dentures, we now had something that looked amazing, that different than what I saw with the blades and so on. These were being what was called osseointegration, and we never looked back. And then we learned what it was that integrated from Brandemark in his great work. We learned what it was that he did that allowed integration. And of course, we've modified it from there since then, along with the rest of the world. So everybody's improved on what was there from that fantastic work and great thinking of PI.
A paradigm shift, for sure.
It was a paradigm shift, and to this day, even today I was lecturing on when to save a tooth or not. And when I went back and looked at some of my old cases of 20 and 30 years ago, and looking at the post-ops on it, the root resected teeth, not many of them around anymore.
Right.
But the implants that I did in 1982, 84, 85, those years, they're still in. Most of them still in, and functioning well. And so there was really, especially the original machined implant, once it took, there was very minimal periodontal problems, and it just kept going and still going. So we saw a whole different shift. And I also realized a lot of the teeth that we were holding on to, these people, besides periodontal disease, also had problems with decay. And so the nicest thing is to give somebody a new root back that doesn't decay. It's called an implant. And whatever implant you choose, it's still no decay. So the crown on an implant definitely lasts longer than a crown on a tooth in most people, especially if the patient's prone to decay or to periodontal disease.
We often hear that endodontics is pre-implant therapy. Do you share in that view?
Not quite. No, as a matter of fact, the person I lectured today with was a great endodontist, and John West, and we had supposedly a debate, a head-to-head debate of endo versus implants, but it's not that way. Endo is just one aspect of treating a tooth, and great endodontists today have a 95 to 97% success rate. So that's not a question. I think that what's a question, so it's not about the apex, that's 3 to 5% failure rate. It's what's left of the rest of the tooth that becomes the real treatment planning problem. So I expect, I work with some of the great endodontists in New York City, and I expect a 95 to 97 percentile success rate. In fact, I get that from them. So that's a given. They could seal an apex. But what's the rest of the tooth look like? And is the patient decay prone? Is the patient periodontally prone? Because they're still susceptible to that, even though the apex, is sealed beautifully. So is this tooth strong enough to take the occlusion on a tooth? What's the fracture rate of posts in general and the fracture rate of teeth? So I see it as what I call the etiological pile. The pile builds up on a given patient. So if you have a patient in your chair and the patient's prone to periodontal disease, prone to decay, and that's why they're in your chair and have lost teeth or have problems in their mouths. It's not just whether or not the apex can be sealed. I assume that's about a 3 to 5% differential of success. But you add the endo possible failures, that's only 3 to 5%. Then there's the other 3 to 5% for each one of those things. Decay rate in 5 years might cause a problem, certainly in 10 years. Post-fractures, post-loosening, debonding of teeth. All of these things become an additional pile. And if the patient's got a few of these things on their list, not just the apex of a tooth being the problem, it is really a pile that becomes overwhelming. And the more things in the pile, you add the endo problems, the post problems, the structural strength problems, the decay rate problems, the periodontal problems, you add them all up, now you got 15%, and suddenly you're more overwhelmed to go towards an implant. So it's not endo versus implant. some of my best friends are some of my best friends are endodontists.
And your best referring doctors too?
And my best referring doctors, they are. We work really closely together, and but if we can't save a tooth, then we go to an implant. But it's clearly a lot of the teeth that I used to do endodontics on, for hemisections and things like that, I don't need it anymore, because other than for temporaries, to hold the temporary, while I transition the person out of those teeth in that quadrant and putting implants in.
Mm-hmm.
So long term, it's a far superior restoration in our hands, and I've been doing both. Being a periodontist and a prosthodontist, I saved all those teeth for so many years. I built my practice originally on being that. If you ever want a great lecture on furcations, I'll be glad to give it to you. I've got a great lecture on furcations, but the reality test is that nobody wants to listen to that. If I had a lecture today on furcations, nobody would show up. A lecture today on implants versus teeth and aesthetics, forget it.
Full house.
Full house.
Yeah.
Full house, right?
Yeah, yeah.
It's kind of interesting.
What would you say the state of dental implant education is today at the university level?
Well, I think it's gotten a lot better. When we first started with implants and realized this had to be more universal, we realized that the kids in school were not getting on almost anything. Some of them were getting lectures. There was like 6 or 8 lectures they used to get, in the 80s, but nothing that's hands-on. It was only for the grad students, only for the prosthodontists, periodontists, and oral surgeons. So the regular generalists that were coming out of school were totally untrained. So, and I really mean untrained. Even if they got some lectures, they didn't know how to do it. So if you missing a tooth, if I'm your first patient and you just got graduated from school and you opened your office somewhere, and I needed a tooth replaced, okay, what are you going to tell me? You've never even done a restoration.
Right.
I think you're going to do a 3-unit bridge, which is what you were trained to do in school. That has finally changed, where now it's a requirement at least to restore some implants in there. Even if you're not doing the surgery, you should at least be able to restore it. And so it's still minimal because of the number of patients. It's more costly in general, although not that much more costly than a 3-unit bridge. But with insurance, it's first starting to cover implants, as you know. So before that, people would say, yeah, well, it's the same price if I'm paying for the 3-unit bridge or a single implant. It might be the same price overall. But what happens is the insurance didn't cover the implant part. So they said, well, my insurance will give me some money for the 3-unit bridge. I'm going to have to go that route. So they were still cutting down perfectly virgin teeth to put 3-unit bridges on. And that's really...
and that's because you think it's easier to sell for the
Well, it's because patients would pay for it, and so they would do it. And of course, the young practitioner was not trained in implants, so they felt comfortable with the 3-unit bridge. They knew how to prep teeth and take impressions, but they didn't necessarily know that much at that time. Now it's gotten better. It has gotten better, more continuing education, better education in schools, better requirements from the universities, and I think that's picked up quite a bit. But the experience level is still very minimal, and so people need more training. They need training, and I think. I was glad to see that you have a training institute here, and I think that this is the kind of thing that more and more people need to be exposed to. That's always the answer. It's all in education.
We agree. What are your thoughts on training general dentists at the undergraduate level to place implants?
Yeah, that's obviously in some respects it's a politically charged question mark there, because obviously it takes the place of what an oral surgeon and a periodontist want to do. And today even prosthodontists, of course, are being cross-trained for certain more easier cases. Because it's ethical for them to now, in their quota responsibility, to get trained in placing more simple cases in terms of placing implants. Placing implants, right now many schools are struggling just to get the implants restored by the undergraduates, believe it or not. But you see routinely in the laboratory, the size of yours, you think that everybody's doing prosthetics on implants. That's not so easy yet. The young practitioners are still gun-shy. They still feel a little overwhelmed by it, as well as so many of the older practitioners who never got exposed to implants during their training. So it's more like the people 5 to 10 years out that are into the new technology, have learned about it, and they know they have a whole career that they have to expose themselves to, and they're the ones doing, I think, most of the work now. But as far as training people in school, to go back to your original question, I think we are just doing a very limited amount when somebody has to have the training. We don't want anybody to take a 2-day course and think they're an implantologist.
Right.
That's where we see the mistakes. 60% of my new cases in my private office today, 60% are redo of other people's work.
Really?
Really. This is an absolute frightening scenario, because it's gotten worse since a few of the companies just did a weekend course and said, no problem. They were into sales. One company in particular was just into sales, and so what they did was they said, you come to us, we'll give you a course for 2 days or a day and a half even in some cases, and then we'll just sell you all the equipment, we'll give you lots of implants, you give us a whole bunch of money, and then you're an implantologist.
Right.
And the reality is that these people didn't know what they were doing. They had no surgical knowledge, they had no background in biology and wound healing, they were just mechanics, and they were bad mechanics, as many of them. And it was just a horror show with what we saw. We saw tons of patients coming in. It keeps me busy, but believe me, this is almost like gut money. It's like, it's hard because the patients are unhappy.
Yeah.
They're angry. And that's not good for dentistry, and certainly not good for the patient, which is really what the main story is. So I think that the proper training is there. I started a program at Columbia to train generalists who want to learn how to do it properly. And I took a look at, I have a two-year program. We do both a little bit. What we do with the undergrads, if they're an honors program, for the placing I'm talking about. For restoring, they always restore.
Right.
You know, for single teeth and overdentures and clip-ons, attachments and stuff like that. But for the surgical part, we are doing a pilot program where just a few of the people who have shown the desire to want to learn more and do the surgery, they go through courses though. During their senior year, they do an elective. And it's in implants and implant surgery, and by the end of the year, we let them get involved with placement of some simple cases. The other thing we're doing, but they have to take more than just their regular courses, they go beyond that.
Are they partnered with a mentor, maybe one of the postgraduate
Well, they're
residents,
partners with the faculty,
okay.
right. And Columbia is a small enough school to have that more personal touch, so we know the students and we kind of work with them, and they come up and they watch the periodontists and the oral surgeons, and then they eventually do it. But they need the didactics too. So they're allowed to come in on the selective to do more education. I started a program at Columbia, either 1 weekend a month for 6 months, so it's like 12-day program, or 2 one-week programs, 6 days, then about 8 weeks later come back for another 6 days. And it's 12 days of didactics and hands-on model work. So it's not a 2-day course. And it teaches the biology of implants, it teaches the wound healing around implants, it teaches anatomy, it teaches the basics to get you entry-level, feeling comfortable with what you're doing, incision designs. These are the things that these people need to feel and be comfortable and know what they should and shouldn't do. So just as much as they know which case to do, they also know, hey, this is for the periodontist, this is for the oral surgeon, or someone trained with more skills. And so they know not to get into trouble. You know, it's not to train them in sinus grafting and stuff like that and big ridge augmentations. No, that's different. And I think eventually, when I look down in the future, what I see happening is that the undergraduate should be trained just like, let's say, an endo. They're going to do the straightforward, simple cases eventually, and eventually be trained in it. As more and more people need them and look for implants, there'll be enough cases to train graduates and undergraduates. But particularly let them get trained in the simple cases that they should know so not to get into trouble. And learn how to do the simple cases, just like a central incisor for endodontics. You know, most practitioners doing endo in their private office, GPs, will do an endo. If they're doing endo, they're going to do a single rooted tooth or something and feel comfortable with it, and be trained well enough to do it properly. You know, start doing a multi-rooted tooth with different canals and different problems and curved roots. You know, and that's what happens. So in the same way that somebody might do root planing, but if somebody has severe periodontal disease, get the patient to a periodontist and should know when to do that and know when to refer. And I think the same thing will eventually happen with implants. There's no reason why a generalist can't learn how to place implants. If they could prep a tooth and they're good at that, there's no reason why they can't angulate an implant, but they must know the biology, they must know the diagnosis and the treatment planning of the case. And therein lies the difference. I could teach a high school student how to place an implant. I could teach a kid right out of school in high school, if they have any kind of manual ability, how to place an implant. Give me a week with them, I'll teach them how to place an implant. They wouldn't know what they're doing though. You'd be like a little monkey. Monkey see, monkey do. Now go do this. And the monkey go does it. But he won't know what he's doing. He just knows, okay, I do this. This is like you can train somebody to carve anatomy in an amalgam or carve an occlusal surface. They have no idea about dental anatomy, just see a picture and they might be an artist and they can carve it. But they have no idea about what amalgam is or what composite is and what zirconium is. That's the doctor. And which material should be used and why. They're just doing because they were told to do it. Right. They become like a technician. That's the level that we want to try to avoid, and by doing proper education, that's what will do it. But do I see people doing it in the future in general practice? I mean, undergrad? The answer is yes. Do I think it's tomorrow? No, it's not. It's just because of lack of number of patients.
Right. If you look at the vast...
But they'll just do the simple cases. They'll know when to refer, and this is very important. The periodontist and the oral surgeon should not be threatened.
As long as they're involved, referring or placing.
They'll be more involved. What I think the oral surgeons and periodontists have done, and as a periodontist I can say this, you know, if you become the teacher, you will be busy. You will be busy. I don't know how else to say that, excuse me. If you If you become the teacher, you will be busy, busier than you can imagine. It's when you try to block it and try and keep everything for yourself and not let everybody grow, that's when it happens. We've only penetrated, as you know very well, in sales, we've only penetrated under 10% of the available market in America today.
Right.
Maybe 8%, 10%, depends on who you read.
At best.
At best.
Yeah.
And it's been that way for a while. Yeah. The expansion is not there, but it can be. You know, other markets have been highly penetrated, you know, like Korea and Japan and places like that. Per 10,000 people, you know the statistics.
Right.
They have much greater, more people who need implants are getting the implants per 10,000 people. So why are we behind? Part of it is lack of feeling part of the general dentist population, who is the main person that the patient goes to and trusts.
The quarterback.
They're the quarterback, and they're the guiding. If they say, oh, you don't want an implant, I'll do a bridge. The patient doesn't question them unless they're well educated and realize that maybe there's another route. And today with the internet, that's helping. But what the people that are training, and I've said this to my own academy in periodontology, don't hesitate to train the generalists now. They've been fighting, in a sense, fighting generalists, and I'm on record of saying this, that by being the teachers, and realizing, let people understand that, listen, if people want to learn something, they're going to learn it. You know, it's just like when I was not allowed to take the course that Brandemark gave, I had to take it as a prosthodontist, not a periodontist. But we had a will. Periodontists had a will. This is something we wanted. And we found a way to learn. Well, the generalist who wants to learn is going to do that too. So why not be the one to teach him or her properly and do it in a proper fashion that's accepted and know what they can do if they want to do it. And then they'll still go to you for referrals for the more difficult cases and some regular cases and for their mother and their father. And what I'm saying is that if we had penetrated the market by 50 to 70%, 60%, then everybody would be looking at each other's cases and we're stealing each other's cases. But because, here's the key, but because we've only penetrated the market by 7 to 8%, maybe about that, give or take some, there's such a room for expansion, for the whole pie to grow. That's when everybody will be happy, including the generalists that may want to do some, as well as the periodontists and oral surgeons and prostheticists. It will expand for everybody. The key is to get the word out there to the generalist and to the patient that implants are safe, they're reliable, when done properly. And you can do your part, periodontists and prostheticists do yours, and I think everybody, and oral surgeons and everybody should be happy that way, because the pie will grow, and therein lies the whole story. Grow the pie, everybody will be happy.
We agree that that metric that you mentioned, the number of implants placed per 10,000 inhabitants, pretty common within the industry. And one thing we've noticed is on the left side of that chart, those countries with the highest level of penetration also correspond to those countries where the cost is the lowest. Not only the cost to the patient for the treatment, but also the cost of the components, the materials, the implants, just the entire cost holistically is lower. Do you think that that's an intentional correlation? Is it a coincidence?
Well, I think it may be part coincidence, because what happens, as you know, is that some of these countries become very ethnically oriented in terms of their nationality. I should say, not ethnic, but ethnics. But they become very nationalistic, I should say. They become very nationalistic, and they'll take companies, well, Korea is certainly this way. You know, whereas the big companies had, pretty good market share, and they had the total market share, really. Then as the Koreans developed their own industry and their own making their own implants, meaning Korean companies making companies, as you know, making implants at even moderate prices, not even really cheap prices or anything, or inexpensive, I should say. That what happens is that they said, okay, I think this quality is there. It's also Korean, and so I'm going to go and buy a Korean implant. And so the big guys, the big companies decreased their value there, and the same thing's happening in Brazil. It's part of that is because of inexpensive, and part of it's money, and part of it is also nationalistic feeling that I'm so proud to be able to place an implant. Because if you look at the originals, the marketplace in the world, you look at, let's say, in Germany, which is a big market, as you know. I mean, one of the German-made implants, was always one of the biggest there, or certainly one of the top 2 or 3. Right. But it's not around the world that way. The Swiss implants, the Swiss is #1 Swiss. Swedish, #1 Swedes.
Right.
So there's a bit of ethnicity, no, I shouldn't say ethnicity, there's a bit of nationalistic flavor to the implant.
It's the World Cup of dental implants.
Yeah, right. So there is some of that. And in America for a while, it was that way too. Certainly strong contenders were American-made implants. Indirectly, it just felt comfortable. And that's what I think is going on. Plus the cost, of course. Today, with the economy being so difficult, certainly in Europe, and also Asia being up and down, and also in America now, we're coming out of the recession, although slowly we're getting there.
So we're told.
So yeah. But we are. I see that certainly in my practice. I mean, 3 years ago, when we were in that real, ready to go over the cliff, literally, I mean, people just stopped spending, and they just, you couldn't tell them they needed full mouth rehabilitation. Those words just couldn't come out of your mouth. It was like, what do I need now to hold me off? They were not ready to spend. And the same thing is happening in Europe right now. I know some of my graduate students who are in top practices, like in Spain, for example. They are in such hurting nature because people are not spending. They don't know what's going to happen to the euro. They don't know what's happening to their own economy. People are not coming in except for the most critical things that they need correctly. And I'm talking about really established practices. I'm not talking about somebody just starting out. So clearly, if economy is affected, so people are going to say, hey, can I get the same quality for less money? And if it happens to be a company from that's in my nation, maybe even better. So I think that that's part of it.
Interesting. Interesting take. If we look at research for a second and the library's worth of articles that you've written over the last several years.
Well, now they're all on a little disc, and there's no more libraries.
Not a bad thing.
Right.
So many papers that you've authored have changed the way doctors treat patients when it comes to dental implants.
Hopefully for the better.
We all think so.
Okay, good.
One of the ones that comes to mind for me is that first paper in 1997 that referred to immediate loading. It was the first paper that had good long-term data showing pretty good results with immediate function, given the right parameters.
Yeah.
What's your take on immediate loading now, immediate provisionalization? Has it changed?
What's interesting with that article, many people don't realize that article exists. I'm interesting that you picked that one. I didn't know which one you were going to choose, what articles. Some people know, I know for the 5 millimeter rule for papilla and things like that.
That's next.
Oh, that's next, okay. But it's interesting, and that's more for teeth, but for implants, what's interesting is Schnittman was the first one to do something like that. He did 7 cases. In 1991, he published an article, and 1990, and he published this article with 7 cases with 3 implants, 1 in the midline and 2 in the back, small ones in the back. And he buried the other 5 in the front. So the patient, legally, if these 3 failed, that the person would still have 5 implants to finish their case, do a regular hybrid case. And when I read that, 3 out of the, so 21 implants were loaded. And when I read that, I nearly fell off my chair. This is 1990. I fell off my chair. Why did I fall off my chair? Because we were all doing Brandemark style implants and everything, and we submerged everything. And here he took 3 implants, and took an old denture, the previous denture, and just secured it like a tripod on the 1 in the front and 2 in the back. And we assumed that all those implants would fail because it's against every principle that Brandemark taught us. No loading, submergence, all the things that Brandemark taught us was being violated for those 3 implants. Immediate loading, non-submerged, everything was wrong. And yet the 3 took. So everybody said, oh yeah, well, 3 out of 21 failed. So it wasn't a high success rate. I was amazed that, that 18 survived.
Right.
To me, I'm the glass half full kind of guy. I'm a positive energy. And so for me, the amazing thing was that the 18 survived. They were not supposed to survive. So I looked at that and I said, in fact, Lenny Linkow was teaching with me at the university. When I inherited the job as director of implantology at the time, Lenny Linkow was involved with some fundraising with the school. So I was involved with Lenny. And Lenny said to me, he's really one of the fathers and pioneers he was really one of the fathers and pioneers of implants. But he was involved with blades as well as screws, by the way. He did screws too. People don't know that he has patents on screws. That's another story. But what happened was, I was amazed that they didn't fail, and they were osseointegrated, no fibrous encapsulation. So I showed this to Lenny. I said, Lenny, look at what Schnittman's doing. And he says, yeah, well, that works. I said, really? He says, well, I've been doing it for years. He said, I have more failures than anybody else, but also have more successes. I said, why did it work? He says, it went around the turn of the arch. He says, as long as you go around the turn of the arch, you'll have a high success rate. Doesn't matter. Just don't take off the temporary, don't move the temporary, and everything's going to be fine. Wait 3 or 4 months, and then even if you have to drill the temporary off, the implants are going to be tight. They'll be tight. I said, tight like osseointegrated tight? He says, yeah, osseointegrated tight. So he says, no problem. Yeah, like that kind of tight. I said, okay. So then I started right afterwards. I started the process of looking at very standardized way of going about it. I said the biggest problem that he had on these 3 was that he said they were short implants. The extra ones he put posteriorly behind the foramen were short and soft to bone. And so I said, what if we loaded 4 or 5? And let's pick mandibles that had plenty of bone. So as the process at school, I said, let's pick a mandible that we can put lots of implants in, 8 or 10, whatever, more than we know that we normally need. But we'll load half of them and submerge the other half. So medical legally, the patient would not have to go through,
Right.
as part of the protocol. Wouldn't have to go
They're
through
good
anything
either
more.
way.
So we loaded 4 to 6 implants on these cases, on these 10 consecutive cases, and over 5 years. And so we had data, as you said, over 5 years. And what was amazing to us is that we had success after success after success. And what it was, we had this down, and we by going around the turn of the arch and having enough support, more than just the tripod effect, by having like the legs on this table, on this chair, the legs had a good AP spread, we call it today, the anterior posterior spread. The further the front implants are, and the further behind the posterior, the back implants are, the more stable, just like your chair. And so what we've realized is that as long as you can decrease the torquing during that loading, lateral forces get diminished. By going cross-arch stabilization, the lateral forces get diminished. And today we know that if there's less than 150 microns of lateral motion, during that healing phase, we don't get fibrous encapsulation. By going around a turn of an arch, just like splinting loose teeth around the turn of an arch, the mobility stops because the fulcrum of rotation is not through all of the teeth or not through all the implants. Fulcrum of rotation is in the tongue area in the center. So there's no easy fulcrum to rotate around. They don't move, they don't rotate, therefore they're stable. So we realized, and today still stands. I'll tell you exactly what Lenny told me, just with a different understanding of what we need to do. You go around a turn of an arch with a good AP spread during that healing phase, the implants take. So I'm very comfortable saying that. And certainly after that 97 article, if you look at, Schnippet once did a review on this. I saw him present. He says he had his article, of course, in 1990, and my article in 97. Between that, there was almost nothing. Almost zero on immediate loading in the 90s. It was amazing. There was one article by some guys in Penn, of course, Henry Salama did one, but that was only a one case report with just an oddball case. Other than that one case, and they came in with up to 5 year data with consecutive implants, everything monitored in the university. That broke loose. Now there are hundreds of articles,
right.
and it wasn't until 97. So
It
I feel good
definitely set
about
the
that. Long answer, but it's a meaningful one because people get into trouble loading single teeth or straight line splints. That's when they get into trouble. If they go around the turn of an arch, they're going to be cooking. You go around the turn of an arch and splint them rigidly, and don't play with the bridge. Let everything integrate for 2 or 3 months. Then you can do whatever you want. They integrate. Same percentage rate as anyone else. Now, of course, everybody knows that. But single tooth, you don't want to do a single tooth and put it into occlusion. That's stupid. Because then let the other teeth take on the load during the healing phase. You just want to avoid lateral forces during the healing phase. So as long as you have good stability, you put a temporary on, keep it out of occlusion, and then let the other teeth take on the load during the healing phase. After that, then you can do whatever you want.
A few years later, you wrote an article in 2000 that...
You've been doing your homework on me.
We've known each other a long time.
Hope I can remember that far. I hope I can remember that far back. Okay, I got the 97 article down. That's good.
In 2000, you wrote an article that has become the standard, widely adopted and remains unchallenged, and that's talking about the spacing between implants and the preservation of the relative inner implant bone height.
Mm-hmm.
Why did it take so long for that to even be evaluated, and what even caused you to look at that?
That's a great question. What caused me to look at it was a patient named Anne Marie. I won't give you a last name. But Anne Marie was a patient in my office, and we did 2 implants next to each other. I put them in, and I didn't know any better, you know, and I put the 2 implants in, and they were a lateral cuspid, and she had a high smile line. And previously I had patients with high smile lines, low smile lines, and I put 2 implants in, and the papilla was a little short, never even bothered anybody. As long as you fill it up and the patient doesn't hiss during their speaking, they accepted it as long as the lip line was low. And she had a high smile line. And then you see the other normal teeth on the left side, but the right side was too short. The papilla didn't come back. And no matter what I did to stimulate it, like I could between teeth with my 5 millimeter roll, I couldn't get it to grow 5 millimeters. It wasn't happening. And so it was right in front of us, but we didn't see what it was. So I did the study with Sang-Chun Cho and Steve Wallace, and we started to look at, on some of our studies where we had implants over years, we started to look at the distance between teeth, and we started to look at whether or not they came closer or not. What really happened is that it was for the first time, the reason why that paper is very significant, it was the first time, if this is the implant, we were all looking at the threads down the side. So if this is the shoulder of the implant, let's say, everybody was looking at like Jan Lindy and Berglund, the great researchers from Sweden, and others, of course, and Boozer and all the others. They were all looking from the shoulder down, which we all wanted to know how much bone loss took place after you connected the abutment and took it on and off a few times, Herman and all the others. So Abramson, they all did these great studies. And they were all looking at different implants, but they looked at the shoulder where the abutment sat on, down to, let's say, what was typically, in most of the Brannemark implants, went down to the first thread. Mm-hmm. Now the first thread people thought it was magical. There's nothing magical. It's just that there's 1.5 millimeter distance, and that's the biologic width reformation. That's what we were looking at. The Brandemark implant happened to be where the first thread was, so everybody thought there was something magical. It is. It's really purely coincidence. We were looking at it, and which we didn't pay attention to was, and I realized it from this one patient, Anne-Marie, and when I looked at the case, I said, I lost a bone between these two implants because they were too close. That's what it looks like to me. So I went back because I couldn't get the papilla to grow back. So it was still too short. In fact, on that case, I had to submerge a perfectly healthy implant. Submerge it. I just published this case actually recently. I published it in a Clinical Advances in Periodontology. So finally, I did get a chance to publish it with Paul Fletcher, one of my partners. But I had to submerge with a big connective tissue graft a perfectly healthy implant and try to build up an ovate pontic in one of the implant sides. And I realized when I went back and looked at the research, what we were missing was everybody was looking at the bone down to how much bone down vertically went. But when you lose down bone vertically, we didn't realize it, but there's a horizontal component to that bone loss. So by having a horizontal component to bone loss, how deep was that? And that was the first article to measure that. It was 1.4 millimeters on that typical Brandemark style implant. So it was 1.4 millimeters horizontally, which means that if these are two implants, besides the bone loss down the side, you might start with implants, but the bone is perfectly normal between the two implants. Here's the two implants, beautiful bone. If you lose 1.5 millimeters, not just vertically down the side, but also horizontally, the biologic width is three-dimensional. The irritation or the inflammation and irritant from the abutment connection moves the bone away from it this way, but also horizontally. So what happens is if these are the two implants, if they're 3 millimeters apart, each of these is separate horizontal components. There's the horizontal component here and the horizontal component here, but the bone peak can stay there. It's not affected by it. If the two implants are closer than 3, they're going to overlap. And so the 1.5 from this and the 1.5 from this, they overlap and the bone crest goes down, therefore the support for the papilla will be missing. And that's what I thought. And so I thought that was the answer. I thought I solved the world's problem. So I told everybody, keep the implants 3 millimeters apart, the bone will be higher and the papilla will come back. So I figured that was the problem. It is a problem. It still is. It's still one of the key things that you must pay attention to. So 12 years later, that's still true. But then I said everybody did that, but still, in many cases, the papilla still didn't come back. So it wasn't just that horizontal distance. Even though the peak of bone wasn't being lost, the papilla still didn't come back fully. What else was I missing, along with the rest of the world? So the article in 2003 was really the pivotal one that helps explain it. And that's where we realized, I went to 5 different offices. David Garber's office in Atlanta, and Salama and Garber, our office in New York City, and Dr. Fromm at Magner and Fletcher. And what we found is what? I went to 5 different offices, and we all came up with the same curve. Any implants, multiple systems, we found that if what was the height of the tissue between 2 implants? What was the peak of tissue? Not to the contact point, because those are 2 artificial crowns. They can be any shape. So, but I said, how much tissue forms over the crest of bone between any 2 implants? What's the average height? And we found the average height was 3.4 millimeters, not 5 and 6, as it is between 2 teeth. And that's when it hit me. We almost never got to 5 between any 2 implants, no matter what they were. And what was wrong? What was wrong is that the piece that we're missing, even if the implants were 3 millimeters apart, we still had the problem. So that we still shouldn't violate the 3 millimeter rule this way. But the problem was that we're missing supracrestal attachment that a tooth has. That's why a single tooth implant looks so good on the lecture circuit. Everybody can't wait to show you a single tooth implant. Because if it's a healthy tooth on either side, the biologic width on a healthy tooth, the connective tissue fibers and epithelium are supracrestal. So they actually wind up help supporting the papilla. That's 2 millimeters of biologic width, supracrestal, not subcrestal. If I have an implant there instead of a tooth, the biologic width is subcrestal, down to the first thread. So my biologic width is below the crest of bone, not above the crest.
And that's how you lose that millimeter and a half.
And that's why the 2 millimeters is short. So that's what we need. And so, so where are we today? The real challenge where we are today, and where we're all working on, is looking at getting attachments onto an abutment and keeping it there, not keep breaking the seal. Keeping the attachments, the biologic width, which we can get to form on an abutment. We have enough data to certainly show that happens. The question is, when we take it on and off, the abutment on and off multiple times, as opposed to one abutment one time, as you hear that, I think Henry Salama quoted that term. But the idea is if we keep breaking that seal, the biologic width goes down. If we get it on the initial healing, on the abutment, we want to keep it there if we can. So that's why we want maybe one change is okay based on Abrahamson, but more than that, it starts to drop down. So we're at a point where what we must do in order to put two implants next to each other in the aesthetic zone, high smile, to keep a papilla, we need to get supracrestal biologic width. Very big challenge, and that's what everybody's trying to work on as we are right now. Between two centrals, we get away with it, because although the papilla is a little short, it's right down the middle. So you don't see any comparison. People just close it down with a little fatter contact point, everybody's okay. So as long as you got a little scallop and no black spot, you're okay, even if it's a little short. But central lateral, in a high smile, with a lateral cuspid, it's your nightmare waiting to happen. In a high smile with a natural teeth on the other side with good papilla, it always looks lopsided to the eye. So that's what we have to be careful about. So
does implant design play into any of these?
It sure does. Well, the first thing that's changed, that original work on 2000 that you asked me was without a platform switch. So now what we're looking at is platform switching. Myself with the Barcelona group, the Bohr group, Nabat and Xavier Nabat and others there, we've looked at this and saw that the horizontal component, when you put a platform switch on an implant, the horizontal component is no longer 1.4 or 1.5 millimeters, like a regular, like the old Brandemark implant was in my numbers in 2000. What we realize now is that the horizontal component's only about 0.3 to 0.5. That because the platform switch is there, and here's the abutment in the middle, if there's a shoulder to the implant, instead of it being straight up and the abutment connection right at there, by having the shoulder, it allows, and here's the abutment connection here, and the bone is out here. This bevel, or this shoulder that's here, allows room for the bone to the bone doesn't have to move away as far to protect to protect the bone from the irritant. The bone doesn't have to move as far away, down. It can stay up here higher because this extra coverage of soft tissue acts as a buffer between the possible irritation of the abutment connection to the bone. So to make a long story short, we lose less bone down the side when we have a platform switch. We only see maybe 0.3 to 0.6 millimeters, depends on which system you see recorded, but under a half, in that range. Whereas we used to see 1.5 to 2. Now we're seeing about 0.5, down from the shoulder. That's from the outside part. That's because there's still a biologic width there. So people used to say, hey, come look at my implant, there's no biologic width on my implant. That's ridiculous. There's always a biologic width. Once the implant is exposed to the oral cavity, there's always a biologic width. There has to be one. The bone covers itself with connective tissue and periosteum. Periosteum covers itself with epithelium. So there's always a biologic width. We'll never change that. So the only question is what? Where is it? Not whether or not it exists. On an x-ray, it might look great. Bone may be covering the shoulder of an implant if you place it deep enough. It is great. But there's always a biologic width. The only question is it on the shoulder and even on the abutment. And if you never took the abutment off, it could be on the abutment. And that's where your biologic width is. So the bone can look great. But once you take it off a few times, the bone will go down a little, but not as far with a platform switch. So I think you're going to see platform switching is here to stay, and I think it'll keep growing with almost every company will wind up with that.
In your opinion, what role can or should a dental lab play in the treatment plan for an implant case for your patients? When should they be involved?
That's a great question. Obviously, there's different ways to come into the digital world. You know, like almost all your crowns now are digital. You're not sitting there with wax. The old guy sitting there with wax and knowing how to use the wax and which type of wax. And
we don't have any of those.
Well, you think about that. You're one of the largest, if not the largest one, certainly in the country, if not the world, and you're all digitalized. And I think this is great. And what it's done is, even if somebody gives you a cold impression, not one that's scanned, so the general dentist or even a prosthodontist, whatever, can enter the digital world right away by just sending you the model. So then everything is digitized after that, as opposed to what's in the mouth. If they can do the pickup in the mouth with the digital, and it's margins that are clear, even better. So I think it's just going to be faster, more direct. You can do email, and then you could transfer back your wax up, so to speak, your electronic wax up. I think that there's no question that it's the way that it'll all go in the future. The kids of today are so computer literate, they're not going to be intimidated by the computer. I think some of the old timers, both laboratory technicians and dentists, are intimidated by that. They know that I want to see a little wax, I want to take off the corner, I want to round it off a little bit, and here the computer does it in about 10 seconds. You know, okay, here's your virtual one, rotate it, like it, okay, boom, and the computer then makes it. There's no question that it's here to stay, and it's only going to get better and used by everybody. It's already being used by all of your people at this point. The only question is, when does the scanning take place? Does it take place by you in the laboratory off a model, or does it take place in the mouth? Never get everything's virtual. You'll never make a model. All the plaster I saw being poured up will probably be obsolete. I think so soon. We hope so. But there's no question that it makes sense, especially when the margins are readable, if they're super gingival and visible.
Is there any impact to the dentist, though? They see their margins now 8 inches around on a screen.
Yeah,
versus
it's a little intimidating if you really look at it. That's why we always, in the prosthetic program, we always have the students trim their own dies. It's the most humbling part of the day. You say, did I really miss that margin? Or did I really prep that tooth that way? As part of a grad student program, this is how they become refined. And in the same way that the patients will, the doctors will see their own. What's interesting, I find, is that I think it'll make for better dentistry. Because if they can do the scanning, not do the old goop, but just do the scanning in the mouth, they can then look at it right away, and they do a digital pickup. In 5 seconds, it's on their computer, if not sooner, right? So they see it on the computer, say, ooh, I missed that margin. Oh, that's not good. Ooh, I didn't really prep that lingual as well as I thought. Let me go back right now. So they can look at it before the patient's walked out of the door. Say, 1 second, just check, nope, okay. So it's almost like having loops, like magnification at the chair. It's like doing stuff with a microscope.
On steroids.
Without a microscope, yeah. It blows everything up, and then you can see your mistakes or the things where you need some fine tuning. I think it'll be lead to better dentistry, because what used to happen is the patient would leave after you did the goop, and they never even saw the poured model. Then after they poured the model, they say, oh, I can't see the margin. Well, there was a bubble there or something like that. I can't do it. They can't. The lab would send back and say, I can't read your margin, or they're afraid to say it. So then they flub it, or they play with it. A technician plays with it, and then it just doesn't fit well, or it's not accurate. So I think it's here to stay. I think the biggest problem is still subgingival, placement of margins and so on. But with implants having standardized size for the most part, you know what the size and shape, you could put impression copings on and not worry about blood. So for implants, as opposed to teeth, it's like a no-brainer. Just scan
no margin.
No margin. Even if it's down there and deep, it doesn't matter. You can put an impression coping on. As long as that coping has an index on it, you then know where the hex is, or the octagon, whatever you have, or tripod. You know exactly where it is based on the abutment impression coping, and you pick that top, take a picture of the top, and the technician can read that and then know exactly where to work from there. So I think it's here to stay. It's just a matter of price and speed at the chair side.
Agreed.
Okay, we've solved the world's problems.
We have solved the world's problems.
I like that idea.
Dr. Tarnow, thank you for joining us today.
It's been a real pleasure, David. Thank you so much for having me here. You have a beautiful facility, and I understand why you're so large in terms of what you're doing around the world and what you're doing here in the States. So congratulations on that.
Thank you very much. You're welcome anytime.
You're welcome. Thanks very much.